Good afternoon, everyone, and welcome. We're so glad you're here. This session is the 5B, Strengthening Community Clinical Linkages through an Essential CHW Workforce Workshop. We will get started momentarily. We're just allowing people to file in and join us. Please let us know who you are and where you are joining us from today. Welcome.
Welcome. Thank you.
Just give everyone a few more minutes. I see people filing in. So if you're just joining us, you are in session 5B, Strengthening Community Clinical Linkages through an Essential CHW Workforce. Drop us a line, tell us who you are and where you are joining us from today. Awesome, Minnesota, our friend Betsy. Hi, Betsy, Atlanta, Kansas City, Montana. Awesome. Corpus Christi. Wonderful. We have great representation in this session today. Hope you all have enjoyed the virtual conference so far. New
Hi, Claire.
Mexico. Yeah.
Claire and we may be relatives. Who knows?
Yeah, there we
Claire
go.
Mooney.
See our friend Carlin and Bill. Wonderful. Well, we're so happy everyone's here today. And we're going to get started. We want to be mindful of everyone's time, and we just thank you for joining us. This is going to be an interactive session, and this is talking about strengthening community clinical linkages through an essential CHW workforce. So let's get started. Before we get started, you can submit questions through the Q&A button, or you could just drop them in the chat. Either one works for us. You can upvote your favorite questions to bring them to the top of the list, and we'll try to get to as many questions as we can. If you haven't already, please introduce yourself, your name, your role, your organization. We'll be dropping some links in the chat throughout, and hopefully we can get across to get to as many of you as possible. So we're going to jump right in. This is how we'll spend our time together today. We'll do some brief introductions. The two of us, the panelists here, we're going to give you a brief overview of the National Hypertension Control Initiative and some of its overarching strategies. Then we're going to dive right in. We're going to talk about some interesting session topics and learning objectives. One, strengthening community clinical linkages. Two, barriers to implementing community clinical linkages. And three, integrating CHWs through strategic planning initiatives. We will wrap us up with our new resource, the NHCI CHW training program, and also leave you with some key takeaways. So let me start by introducing myself. My name is Kyna Shine. I am the National Director of Program Implementation for the National Hypertension Control Initiative. I work for the American Heart Association and have been a part of this grant initiative for the last 2 years. And I am joined here today by my colleague, Mark.
Hello, everyone. My name is Mark Mooney. I'm the National Director for Program Development on the National Hypertension Control Initiative with the American Heart Association. Thank you for joining us.
Thank you, Mark. All right. The National Hypertension Control Initiative is a project that's supported by cooperative agreements with the Office of Minority Health, the U.S. Department of Health and Human Services, as well as the Health Resources and Services Administration, or HRSA. This is a 3-year federal grant that we are wrapping up, and we are now in the evaluation part of this grant. So let's just start from the basics here. The National Hypertension Control Initiative, what is the purpose of it? It is to improve hypertension control in community health centers and communities across the United States, with a specific focus on populations that were disproportionately at higher risk of adverse outcomes with COVID-19 and with uncontrolled hypertension or high blood pressure. These populations are specifically Black, Hispanic, American Indian, and Alaskan Native people. And we did this through broad-scale, multi-sector, culturally relevant and appropriate, diverse evidence-based models and interventions, including self-measured blood pressure monitoring. And these are our 4 overarching strategies of the National Hypertension Control Initiative. One is around healthcare organization and healthcare organization providers and clinician training. We wanted to make sure that people in the clinical settings had the tools, the resources, the science-based information as much as they could from the American Heart Association. And we served as an extension of their team to help implement self-measured blood pressure programs. In addition, we focused on community outreach and integration. This is really where community clinical linkages came to play, and we focused really heavily on this in year 3. We also provided patient and public education through workbooks and self-measured blood pressure education and awareness to empower patients to take control of their health. And right now we are in the evaluation part of the phase of this initiative. So let's talk about the session objectives, what we're going to do today. Our first objective is discuss how to strengthen community clinical linkages. And by doing this, by fostering relationships in healthcare, both in the clinical setting and in the community setting. Excuse me. Our second objective is to identify major barriers to implementing these community clinical linkages. And finally, our third objective is to explain the importance of integrating community health workers into the strategic planning process from inception to evaluation. And I think this is a really key part of this workshop, because so many times community health workers are brought in at one point or another versus the end-to-end process. So we're going to start with building bridges. How do we strengthen community clinical linkages for better health? We're going to launch our first audience poll. And this is really casual, super informal. We want to know, how do you define community clinical linkages? Just give us the first word or first thing that comes to your mind. How do you define community clinical linkages? All right, I see some answers popping in. We'll give you about 30 seconds, 30 more seconds to complete the poll. And if you don't know, that's okay. That's why we're here, to help and share. We'll give you about 10 more seconds. First thing that comes to mind. All right. Miss Sophia, will you show us our answers and the results? I'm not sure if you guys can see the results. I cannot. Let's see.
Are you able to see them now?
Not yet.
Okay, let me stop sharing and reshare here.
Okay, thank you.
Results sharing now.
Okay. I am not able to see them. Are you, Mark? Are you able to see them?
Oh, I'm not. Let's see here. What? No, I'm not seeing them. But
Gotta love technology. It's okay.
that's okay. And some of the participants, they don't see them as well.
Okay. How about we just put them in the chat? If you don't mind, just go ahead and put them in the chat and we will see what you said. How do you define community clinical linkages?
Collaboration, referrals, connecting points for patients.
Awesome. Yeah, we see connection points for patients, referrals, collaborations designed to improve the health of the community, communication. All of those are absolutely correct. coordination, absolutely. Continuity of care, team care.
Yes, beautiful.
Absolutely. Thank you, Betsy, for sharing. They do play a crucial role in promoting preventative health, 100%. Thank you guys for engaging with us. Excellent. Go ahead, Mark.
Okay, well, let's go into the details. Here we go. So, what is community clinical linkage? So, according to the CDC, um, through their community clinical linkage practitioner guide, community clinical linkages refer to connection established between community sectors and clinical sectors with the goal of improving populations' health. So the first sector, community sector, it includes organizations that provide services or services programs or resources to a community member in a non-healthcare setting. And that could be a faith-based organization, barbershops, nonprofit organizations such as the YMCA, and community centers. In a clinical sector, this is a sector that provides services, programs, or resources directly related to medical diagnosis or treatment of community members by healthcare teams in a healthcare setting, such as hospitals, group practices, rural clinics, community clinics. So research shows that when healthcare professionals and community leaders, such as community health workers, work together, patients can experience healthier lives. So on the next slide. So on this slide, this is a framework of community linkage to care that was published in the journal Primary Care and Community Health. And this is an integration this framework is to integrate key elements such as social needs screening, referrals, follow-ups, healthcare professionals, administrative liaisons, and performance improvement. And we can demonstrate how community health workers can be integrated with the focus, of course, in improving blood pressure in both a community-based organization environment as well as a community health center environment. And so, like for an example, the social needs screening, includes standard process for screening for social needs, which we will touch upon further in our presentation. Referrals include standardized process for making referrals to community health centers or CBOs or community resource. Follow-up includes regular follow-up with patients, community members, and families. Healthcare professional include a designated clinician base at a community health center who provides leadership. Administrative liaison includes leaders to provide program support, direction, and supervision. And performance improvement includes using data to provide feedback and improvement. So now let's take a closer look at the role of a community health worker in both a community and clinical environment. There we go. So this is an example of how to operationalize the framework or just put it in action. And so this approach helps bridge gaps between healthcare systems and community resources, ultimately enhancing services delivery and access. So the first stage you see here, networking. Networking, this stage is where entities exchange information in an organic manner without any standardized processes. Stage 2, coordinating. This stage is where the entity begins to exchange information and alter activities in a more structured way. And the tool that will be used, that one can use, would be a social navigation platform, which is critical in facilitating the coordination. Stage 3, cooperating. This stage is marked by not just exchanging information and altering activities, but also sharing resources. This is where adding a community health worker is crucial at this point of the stage, ensuring more direct support and resource allocated within the community. Stage 4, collaborating. This is where stakeholders are deeply engaged in exchanging information, altering activities, sharing resources, and enhancing each other's capacity. So this is where local learning collaboratives come into play. And they're introduced to create a network for shared learning and capacity building. This stage requires a more intense operational efforts with focus on enhancing collective capacity. And the final stage, merging, is where all the entities operate as a single entity with blended roles and culture. This stage represents social transformation with full and integrated between the community and clinical entities. Now, on the next slide, what we have here, this is how we want to share with you guys how we really design a pilot program using the framework and the approach I just shared with you all on the NHCI pilot program. So what we want to do, we just targeted in 5 areas, as you can see: state of California, Michigan, Maryland, Texas, and Puerto Rico. And so in these 5 territories, of course, our deliverables here were, CBO, community-based organization, and health centers integration, establishing a learning collaborative, and ultimately developing a community health worker training program. And internally, we along with the NHCI team, we also partnered with our local teams, which are called the Community Impact Directors, the Public Health Program Managers, which were part of the NHCI team that provided a lot of technical assistance, as well as the program development team. And as you can see, the community-based organizations that we partnered with: California, Mission YMCA, Northern California Center for Wellness, and Samuel Merritt University. Hope Village in Detroit, Michigan, One Stop Career Center in San Juan, Puerto Rico. We partnered with the Black Nurses Rock in the Maryland area, and we partnered with the Links and Black Nurses Rock chapter in the state of Texas. And so what we also want to share with you is on the next slide, please. We wanted to share with you, highlight one of our community-based organizations, which is One Stop Career Center, as you can see, of Puerto Rico. This is a private nonprofit organization, and their aim is to impact areas of the greatest need for their population, such as housing, education, employment, health and legal services, offering service programs that can be integrated and offer alternatives to the communities that are in need. And so the purpose of this project, working with the CBOs, was that we partnered with CBOs to implement the community clinical linkage to improve hypertension awareness through our Empower to Serve health lessons, link participants to social services using a social navigation platform, enroll in an SMBP, which is a self-measured blood pressure program, and provide education via the community health worker, linking them to the health centers. And the methods of that is that the CBOs were charged to enroll up to 200 participants, facilitate the ETS health lessons, conduct blood pressure screenings throughout their communities or the areas in which they were targeting, social needs assessments, and referral services to health to the health centers, and non-health issues using a social navigation platform to the related agencies. And over there on the right side of the screen, you see the timeline. You know, we back in November to December 22 is where the NHCI team, you know, we convened to design this pilot. And then in February to April in 23, this is where we allowed the CBOs to develop and create their workflow. And then from May until the end of last year, where the CBOs had implemented, executed their deliverables. And so I want to highlight one-stop career centers. So their approach, they implemented in 10, and if you actually go to this is Puerto Rico, and this gives you a visual of the 10 communities in which they reached. They implemented in 10 rural communities in Puerto Rico. They hired CHWs to be part of this, to execute and work with the community, the participants of that. They also partnered with 10 community health centers. They facilitated the Empowered to Serve health lessons. Control your blood pressure was one. Get active, salt and cardio of health, and know your diabetes. And as a result of that, as you can see the outcome, One Stop Career Center, they enrolled over 600 participants, again in 10 rural communities, with partnering with 10 health centers. They made over 200 referrals using a social navigation platform. And as you can see on the screen, Associates was the social navigation platform that they used. Some of you may be more familiar with social navigation platforms such as Unite Us and Find Help. So, we at the results, the outcome of that, it suggested that that the ETS modules, the health lessons, when facilitated by community health workers, it enhanced hypertension health literacy, awareness, and improved confidence to support lifestyle and behavior changes, which we were very happy with working and collaborating with One Stop Career Center, because they took the torch and they ran. I mean, it was just awesome. So I'm going to pause for a minute and find out if there are any questions. Do we have any questions?
Yes, Mark, there is a question in the Q&A section, and he said, Bill proposed this question. Have you seen any barriers in sharing information related to perceived fear of violating HIPAA? And so I had a chance to think about it a little bit while you were presenting. And I think, you know, the health centers and the CBOs that we partnered with had their standard forms and procedures in place that we vetted prior to partnering with them. And so, and the social navigation platforms as well. So both social navigation platforms were HIPAA compliant. And so the CHWs were serving as a liaison with the community-based organizations and the health centers following their protocol. Right. So that's the best way we could address any type of HIPAA compliance and violations.
And you know, that was very covered. The health centers made that very clear, because the community health workers that work directly with health centers, they would have to go through their HR protocol and sign off on in terms of what is revealed and what is not revealed. So, but for the most part, no. And then also in some cases, they were coded in terms of surveys and response to out of the health lessons. Hopefully that answered your question.
Yeah, great question, Bill.
We did not have any HIPAA violations at all, or no. that question did not come. No, but thank you for that.
Any other questions on that section? Absolutely. Okay, well, we're going to please continue to add questions into the chat, and we will be monitoring that or in the Q&A function. We are going to move forward with paving pathways and addressing and overcoming barriers. I know a lot of us do community work and clinical work, and we could talk about barriers all day, but one thing we want to focus on is also being solution oriented. But let's talk about addressing and overcoming barriers. With our NHCI pilot, some of the barriers that we faced that can hinder community clinical linkages and their optimization was number one, leadership buy-in. Whether there was a lack of awareness or understanding with leadership about the benefits of a social navigation platform or a community clinical linkage, or maybe there's resistance to change that truly could hinder the optimization of a community clinical linkage. On the flip side of that, a facilitator that really supported community clinical linkages was around leadership that recognized the importance of addressing social determinants of health and that were committed to innovation and improving patient outcomes. So we looked at it both ways because we saw several examples of integrations that and linkages that were successful because of those things, and then some that were not so successful because of the barriers that we shared. Another one was around organizational infrastructure for implementation. So for instance, what we heard over and over and over again was insufficient budget, right? For infrastructure upgrades, or maybe their IT teams were overburdened with competing priorities. Those were some of the barriers that we heard. On the flip side, sufficient IT support and resources really supported community clinical linkages and availability of necessary hardware and software. I know on the more organic end of the continuum, there's not as much technological integration, but as things become sometimes more complex, that's where the technology integration comes into play. Another one in our experience in our pilot was around consistent self-measured blood pressure program onboarding process. So some of the barriers that we faced were insufficient training, resources, and materials for both clinical staff, community-based organizations, community health workers. Or they're just, there was staff resistance to new processes and technology and new ways of doing things. But when we did see success was when there was well-documented onboarding processes that could be adopted for either adopting a new tool or implementing a new program like self-measured blood pressure. And existing experience with existing technologies or similar healthcare technologies. It really does accelerate the adoption of that technology. A documented process workflow. Some of the barriers that we saw were resistance from staff, changes to workflow. Change is inevitable, and that's the one constant in life. But sometimes the lack of clarity in how the platform or how a change in process can fit into existing processes would hinder the process and the community clinical linkages. When there was a well-defined workflow for social navigation platforms, when there was a well-documented workflow for new processes, that's when we saw the community clinical linkages really optimized. Moving forward, a systematic way of addressing social determinants of health. Most of you are familiar with the PREPARE tool, but sometimes some of the barriers where we saw were limited knowledge of available community resources. And so not really sure, community resources are changing constantly. And so sometimes not knowing what's available and being able to point and guide people to those resources when they need them, that was a barrier. Then also challenges in coordinating care with external organizations. So we might be able to identify a resource for a patient or a community member, but coordinating the follow-up and the care that they need so that they can address their blood pressure, that was sometimes a challenge. But when there were clear guidelines and protocols for addressing social determinants of health, within the community health center or the community-based organizations setting, that's when we saw success. Also collaborating with community organizations and resources. These collaborations, when they're organic, when there's history, when there's trusted relationships involved, that's when we saw a lot of success. And then dedicated staff to create and track referrals. When we we heard over and over again, staffing shortages, there's capacity issues, attrition, retraining people. This is definitely a hindrance to community clinical linkages, as well as, recruiting qualified staff and retaining them. But when staff were trained, they were able to manage the referrals. And when we had adequate staffing, there's someone to handle that workload, someone to create the referral and monitor it and close it out and follow up. And then the electronic health record. The facilitators and barriers here, sometimes the barriers that we saw where there was a lack of interoperability. So, one system can't talk to another system, or this system can only talk to certain systems. So understanding kind of the interoperability between social navigation platforms and EHR systems. There's also limited resources and budget. We heard that tons because you want it to be custom to your community needs. And so understanding kind of the scope and the budget and the staffing and the interoperability technical requirements was important. Some of the facilitators were around compatibility with existing EHR systems and understanding which ones talk to which social navigation platform is the best, and support from EHR vendors for integration efforts. So for example, if you implement RPM or remote patient monitoring or social navigation platform, and you're asking your staff and CHWs to help with that, it's always nice to have like a tech support accessible so that they can help navigate any issues that need to be troubleshooted. So those were some of the barriers. What other barriers have you faced when implementing community clinical linkages? Just drop them in the chat. We're going to just keep it easy, but we want to know, what barriers have you faced? The ones that we shared on the screen before were just a few of the ones that we faced when implementing community clinical linkages, but we want to hear from you. Are there any other barriers that you faced outside of budget and staffing and technology? We'll give you a few seconds to share. I'm not sure. Let me check the chat. Oh, yeah. Gaps in closing the loop and those bi-directional communications. Absolutely. Thank you for sharing that, Megan. It's not just one way, right? One directional. It's about these bi-directional referrals and that constant feedback loop, right? And understanding what happened. Were we able to address the situation and the need? And was there a follow-up need? So that's a great one. Thank you for sharing, Megan. So closing the gap. Any other barriers that you've faced before we move on? Okay, seeing none, we will continue. Oh, that's a good one. Thank you, Laura, for sharing. The lack of a model for CHWs. Absolutely. That's a great one. I think models and pilots serve as examples and blueprints for this kind of work. So that's a great one to add to the list. If you all think of others, feel free to drop them in the chat. These are great. We're going to continue. So here are some solutions to optimize community clinical linkages. And these are not the end all be all, but really it's around identifying barriers, fostering communication and collaboration, and providing that training and education, just as Laura mentioned, like a model for CHWs. some of the learnings that we gathered was the importance of conducting community needs assessments and assessing partner readiness. Sometimes, we have these great strategies and plans that we're ready to implement, but really understanding our partner's readiness and capacity can be a deal breaker. Identifying our target population with so many different needs out there, it's important to stay focused and identify the target population. So in our case, it was around those populations that were disproportionately impacted by COVID-19 outcomes and uncontrolled high blood pressure or hypertension. It's important to outline objectives and then develop staff and patient education tools. This will set you up for success. Moving on, other solutions include securing resources and funding, aligning policies and procedures, and using technology and data. So when it comes down to it, it's about resource planning, understanding how we can build capacity, not just for the program, but understanding how to build capacity within the community that's sustainable. Also identifying collaborative advocacy efforts so that you can leverage different policies that are going in place. And one that comes to mind was around the state of Maryland and, reimbursing for SNBP and, supporting CHWs. So understanding advocacy efforts on a local and state and federal level are extremely important. And then leveraging technology, such as social navigation platforms like Find Help, Unite Us, Social. So we're not endorsing anybody. We're just using those as an example. But to really close the loop to the comment that was provided earlier to those bi-directional referrals. Other solutions to optimize community clinical linkages, including engaging the community and evaluating and adjusting on a constant basis. So you have to engage stakeholders, throughout the entire process and share resources and services. You want to request feedback at every point of the process so that you can get those constant feedback loops and pivot and adjust your program as necessary. Leverage program data. Data-driven programs can drive decision-making and can drive improvement. And so that program data is critical to, optimizing community clinical linkages. And then also integrating innovative approaches. One thing I know about community health workers are they're some of the most resourceful professionals and innovative professionals. And so integrating innovative approaches that meet the needs and meet the values of the communities that you're serving are extremely important. And then planning for sustainability. It's important to provide support to communities, but we really want to focus on that sustainability piece. And Mark is going to talk about that in just a few minutes. Any questions in this section? This one was around addressing barriers. Any other questions that came to mind? We're happy to address those now. One question was, will the slides be available after the presentation? Absolutely, we are happy to share. All right. All right, Mark, I believe this is your section.
Great, I believe it is. Maximizing impact. Integrating CHWs in strategic planning and initiatives. So we have another question, and you can answer it in the chat if you don't mind. Which leaders, and I'm sure you all know this answer, which leaders are responsible for linking individuals to resources and clinical care in your community? Take a guess. I know the answer. CHWs, right? Right. All right, Kenan, why don't you move to the next slide? So I'm going to talk to you the importance of integrating CHWs into strategic initiatives requires a seat. CHWs must have a seat at the table during every phase of the process to inform the work. The CHWs play a critical role in community initiatives by providing cultural competence and community trust. It is a necessity that CHWs be involved in every phase of strategic initiatives, ensuring that the community voice is represented and valued throughout the entire process. So let's go to phase one. Phase one, what is the history of the organization in the community? Understanding the history of the organization within the community is very important. CHWs can share insight in past successes and challenges, helping to tailor initiatives that resonate with the community needs. An example of that would be a CHW who are longtime residents of community can help program leaders understand previous failed attempts to introduce health interventions, allowing the new initiative to avoid past mistakes and build on existing strengths. That's why CHWs are important. Second phase, who will be impacted by the initiative? CHWs have a unique perspective on who is impacted by the initiative by helping to identify and prioritize vulnerable populations and ensuring that interventions are equitable and effective. An example of that could be a mental health awareness campaign. CHWs can identify that the stigma surrounding mental health in the community was a significant barrier. We're talking about barriers. As a result of that, by integrating CHWs, they could help design the program that first address stigma and leading to greater community participation. Phase three, who has the cultural competence? CHW will ensure cultural competence is identified or included directly connection to the community, allowing to bridge cultural gaps, making programs and more accessible and acceptable in diverse populations. Phase four. There we go. How will the program be implemented? So CHWs can contribute here as well in planning and implementing phases, providing practical insight and helping to address potential barriers earlier on. An example of that, for example, is just say that you wanted to do a nutrition program in the community. CHWs can identify local markets that were not stocking the recommended healthy foods. Their involvement allowed the program to partner with vendors, ensuring that healthier options were available and accessible during the implementation phase. And then now phase five, how are we building capacity in the community? As we know, CHWs are leaders and educators within the community, therefore are important when building capacity. This empowers community to sustain health initiatives even after the program concludes. For an example, improving blood pressure initiative that trains CHWs to lead support groups in their communities, such as the CBOs that we work with that I shared with you earlier. These groups continue to meet and support new members even after a former program ended, showing how capacity building through CHWs can sustain health behaviors over a long period. Phase 6, who is collecting the data and who will have access to that data? CHWs in collecting data collection is very important. It emphasizes their ability to gather accurate and relevant data due to their trusted status within the community. They ensure that there's clarity on who will have access to this data and how it will be used to inform decisions. A real good example is a community needs assessment that most of us may be involved in doing in communities, right? CHWs are trained to conduct household surveys. Them being a trusted individual within the community could lead to more honest and complete responses, resulting in more accurate data that guide effective health intervention. Phase 7, what changes, should we make to improve the program? It's an ongoing role for CHW in evaluating the effectiveness of the program, providing feedback on what changes are necessary to improve outcomes. For an example, the heart disease prevention program. The program used CHW's feedback to refine the approach midway through the program. And most of us have worked on programs and projects where we had to pivot based on feedback from our community partners, such as CHWs. And finally, sustainability. Who will sustain the work once the initiative concludes? That is why CHWs are key players in ensuring that the work continues to benefit the community long after the initial period has ended. And so now I want to share with you some, where does a CHW fit? What role do they play in a CBO? Using the framework that you see here, the role of the CBO, can be working the social navigation platform, as we discussed earlier, in one-stop career center associates, health lessons, administer health educational programs, work with self-measured blood pressure, being an advocate for those individuals in the community, and that they have a trusted relationship, and they can get the referrals to health centers. That's what a CBO looks like on a community-based organization, working with a community-based organization. Now, CHW in a clinical setting, using the same model. The social navigation platforms, as Kyna kind of alluded to, some of these social navigation platforms may or may not be integrated into the EHR systems. Prepare assessment. A lot of the health centers that we worked with, they prepare assessment tool is embedded into their EHR systems. CHWs can work closely with medical staff with medication adherence, being the cultural broker of trust, and just being an overall patient advocate for patients in the clinical setting. Those are just some examples that we'd like to share with you. So on the next slide, I guess, well, let's see now about Kyna and I have shared a lot so far. So we just want to pause right here to see if there are any questions that you have so far, what we shared with you.
Yeah, Mark, there was a question in the chat, in the Q&A function. It says, is there a preferred implementation model? The model that we followed was the CDC's practitioner's guide for prevention, for disease prevention, excuse me. And
Right.
so that one is a well-documented piece of literature that's available on the internet. And that's one that we use for our implementation and helping us to operationalize the model for our program. I don't know if there are others, but if there are others, please feel free to drop them in the chat.
Yes. This was the community linkage to care
Yes.
framework that we use.
All right. Great. All right, Mark, so we'll move forward with the new resource, our new NHCI CHW pilot training program.
Yeah. And so thank you, Kyna. And so over the course of this work and the collaboration with our community partners, community-based organization and health centers, we saw a need where we could enhance community health workers' professional development. And so we decided to develop a community health worker training program that specialized in improving blood pressure. And it was a pilot. So the next slide, please. But I have a question for you. This is the last poll question, I promise. Approximately how many CHW CEUs hours do you earn per year based on your state? This was something that we learned along the way. If you can just drop in the Q&A or in chat, put the number of, in order to renew your CHW certification in your state, put the number and then put the state that you're in. 20 and 2 years in Missouri. Okay. Okay, Miss Claire, Miss Mooney. What can you put in what state you're in? This is good. Florida 20. So let me tell you something. When we were, Kyna, you can go on to the next slide. This is great. So our community training program, again, it was designed to equip and empower CHWs to coordinate cardiovascular care in both the clinical setting and a community setting. The specialized training really focused on the community clinical linkages. And our training program are on-demand courses backed up with AHA science. And so our continuing education units that we sought out were targeted in our pilot states that we worked with: California, Maryland, Michigan, and Texas. And we asked that question in terms of what were your number, what is the requirements, the numbers in your state, because in doing this work, we discovered there was no one governing body for all CHWs to report to and adhere to. CHWs were regulated by their states. And guess what that means? Every state is different, as you can see in the chat. Some states have a requirement or regulation, and while others may have 20 every 2 years, some may have 30, and so forth. So what we did was that in the state of California, that was the state that did not have requirements, but they are currently working on creating guidelines to enforce in the state of California, I know this year, 2024. Maryland was a state that they required, but they accepted our program as to go toward professional development, and which eventually will count towards the renewal of certification of CHWs in the state of Maryland. Michigan, they approved our program or CHWs to receive 7.5 um, 7.5 CEU credits. And in Texas, we got approved as a training center. And you know what? I'm gonna push along because I know we getting close to time. So next slide, Kyna, you don't mind. So real quick overview. So gave you an overview of what the program is all about. Objectives, of course, improving understanding of health consequences of high blood pressure, identify risk individuals, how to assess blood pressure accurately and interpret the reading. Our training promotes healthy lifestyles and to prevent high blood pressure, social navigation, and really we have modules that's designed to work closely with a healthcare professional. And so on the next slide, the training, currently our training program is gated. It's gated to those CHW participants that have been part of our pilot in those states. So currently they're gated, and it will be available to the public after in 2025. But let me just focus on like their on-demand modules that are facilitated by CHW instructors certified in Texas. There are 7 modules that are available in English and in Spanish, and they range from 30 to 45 minutes each. And of course, based on AHA science. And then after you complete all 7 modules, to receive a certificate of completion, you must participate or watch at least 2 of the monthly conversations that are part of the portal, complete all 7 training modules, and complete a pre and post assessment for each module. And the next slide will just kind of provide you with the topics of our monthly conversations that took place from September to December. Participants will select 2 out of the 4 if they didn't already attend all 4 live. And the next slide, it provides you with the 7 modules. And here are the titles. Module 1, Introduction to Community Clinical Linkage. Module 2, High Blood Pressure Awareness. 3, being proactive with high blood pressure. 4, blood pressure screening, assessing blood pressure and interpreting the readings. 5, preventive strategies for high blood pressure. This is really to promote healthy lifestyles. 6, addressing social determinants of health. And 7, the care coordination and effective collaboration. CHW is collaborating with healthcare providers. And again, I just want to emphasize that this is gated currently into the end of our project, and will be available to the public in 2025. Are there any questions? And if not, I'm gonna turn it over to Kyna to close this out because I know we're almost running out of time. There you go, Kyna. Thank you.
Thank you, Mark. There was a question in the chat. Was this the same training from Texas A&M? And I don't believe so. This is unique to the American Heart Association. We had a lot of different stakeholder input from, Nashua and Betsy Rodriguez, who's on the call, to our local partners at the American Heart Association. So this is unique with a specialization on blood pressure control.
And also to emphasize that there were some local markets within the AHA that kind of created a different approach or style of training, which is not as in-depth as we have provided here with our community health training program. So Bill, I hope that answers your question. Thank you.
Thank you, Mark. So we're going to wrap it up. Please continue to drop your questions in the chat. We want to wrap this up with key takeaways. And first, we want to encourage all of you and all CHWs to continue engaging community-based organizations as strategic partners. Our pilot proved to be extremely successful, and We could not have done this without the support and the leadership of our community-based organizations. We've heard, community health workers sometimes have a challenge navigating between the clinical sector, between the community sector. And so really understanding that integration and partnering with CBOs was the way to go. Second, leveraging evidence-based models, utilizing the community clinical linkage approach was a tactic that we use to connect people to clinical care on the one hand, and to identify and address social services on the other. So we're really trying to make this an integrated approach that had wraparound services from the community sector to the community sector with the input from public health experts. In addition, we used learning collaboratives and listening sessions on a local level as a strategic approach. We wanted to make sure we were hearing and understanding what is actually happening, boots on the ground, what's working, what's not working, and understanding those themes. One theme emerged loud and clear, and it was an emphasis to integrate community health workers into this work across all 5 pilot markets. And so we would not have known that without doing these listening sessions, and community health workers served various different roles across the different pilots. Endorsing CHWs as clinical care team members and CBO providers of care. We partnered with some CHWs, and in some instances in a clinical care setting, they really didn't know their spot. But when we partnered with CHCs that were really open and had designed workflow processes that incorporated community health workers from inception to evaluation, that's where we saw the most success. Same with the CBO approach as well. Continue to build stakeholder relationships. This work is around brokering trusted relationships in the community, and there's nobody better to do that than community health workers. And proactively addressing social determinants of health. This is key to really addressing health disparities, chronic diseases and conditions that individuals face, and improving better health outcomes. It starts with addressing those non-medical drivers of health. And last but not least, we hope that you visit our website for additional resources. As Mark mentioned, the actual CHW training program is gated right now. We are in the evaluation part of this process and this grant, but in 2025, all of the information will be public for community and public consumption. So we want to really thank you for your time today. That's all we have. Please drop any questions that you may have in the chat. Feel free to connect with Mark or myself on LinkedIn. And we really, truly appreciate you joining our session today. Are there any questions? If you have any questions, feel free to email us at nhci@heart.org. We'll be happy to address your questions there in that inbox. But until next time, we appreciate your time and attention. Before we conclude, I see a question in the chat from Jessica. Will there be a cost to the training? No, this is a free training. We use federal dollars to create the training, and so this is taxpayer money. It is going to be free for the public in 2025. We want to thank you, and we also want to thank the National Association of Community Health Workers for inviting us here today and to be a part of their conference. So until next time, thanks everyone. Take care.
All right. Thank you all. Take care and thank you.